which is needed if we would like to expect beneficial result. We need to increase serum albumin concentration. And with the loading dose, this increase about 0.8, 0.7, 0.8, 0.9 gram per deciliter occurs within a month, and then remains steady. This is important, I think. The sooner you reach a critical level, the better it is.
Got it.
It may also be the case that in particular situation, we should give even a greater amount of albumin, at least in the initial phase. And we do, but this again is empirical. It's not evidence-based.
Right.
The point is that a clinical trial made in Barcelona, Spain, who used albumin and midodrine in patients with cirrhosis, that they were included in the waiting list for liver transplantation, gave half the amount of albumin that we did, 20 gram every 15 days, and the result was that the serum albumin concentration didn't change. And the final result is that the mortality was not improved, did not improve, and the incidence of complication was not reduced. So I mean, if we would like to have beneficial effect, we have to increase serum albumin concentration, and so we should give an amount of albumin able to induce this. Of course, this may be different from patient to patient. Right. If you have a severely ill patient, you may be you may need to give an amount of albumin far higher with respect to the ANSWER study, for instance.
That makes sense. That makes a lot of sense. All right. And then another question that I had was that when we are doing this real world study, when, talking to physicians, asking them what are the benefits of long-term albumin, and if they've noticed fewer hospital admissions, a lot of them say that the number of hospital admissions haven't really decreased.
Yes.
What do you think could be the reason for that?
Reduce incidence of complications.
They're saying that it has not happened, though. That they still see their patients coming in about the same number of times due to complications as...
You admit to the hospital a patient with a complication.
Right.
Otherwise, why it should be in hospital.
Correct.
And we clearly demonstrated that the incidence of the common complication of cirrhosis, from renal failure to hepatic encephalopathy, to bacterial infection, especially spontaneous bacterial peritonitis, hyponatremia, hyperkalemia, all these complications were significantly reduced by albumin administration. So, I mean, if your patient makes 5 episodes of hepatic encephalopathy in 5 months, and then makes 1 episode of encephalopathy in 5 months, plus 1 very mild, that can be handled in the outpatient clinic, of course. Right. The need of hospital is decreasing.
Right. Okay.
This is the main reason that the long-term albumin administration is cost-effective.
That makes sense. And one follow-up I have is that do you think that patients are doing better just because they get more physician attention with long-term albumin since they're interacting with physicians more? Or is it truly because of the long-term albumin effect? Because both of those things are happening, right? You are also getting more attention from your physician.
I'm laughing because this is one of the struggles that we had with the reviewers, because our is an open label study.
Right.
And what can I say? I'm convinced that this is not the case. But I cannot deny that a component may be the fact that the patient are followed up more closely. The point is